Thanks, Sarah, for joining me and, talking about one of our mutual favorite subjects,
Totally.
trauma and, your specialty, at least your background in addiction.
Mm-hmm.
We were chatting at the training recently about the interplay between complex trauma and addiction, and specifically treatment for
Mm-hmm.
trauma and addiction. And I know you had some really great perspectives on it, so I'd love to kind of just jump right in.
Yeah, I mean, when you talked about the connection survival style, I feel like that's the place where most of my clients that I see with addiction issues, I think that's where things went wrong, like straight from the very beginning. And as you were like describing that type of person, I was like, yes, 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 going down like my caseload.
Yeah.
And it's interesting. So I've been thinking about this and, reactions to your webinar with Larry about, addiction and NARM and how that all goes together. And I think one of the things that's really frustrating for me, the more that I learn about addiction treatment in different parts of the country, it's so different. Like in Chicago, I think our treatment centers actually do a pretty good job of actually giving mental health treatment and addiction treatment concurrently. But I hear, I spent some time in Texas, and their market sounds like it's really 12-step facilitation based. And then also in the Northwest, same. And so I'm going to be curious, like hopefully getting to do more of this and introducing NARM to different treatment centers. Who is going to be willing to open to this and who isn't?
Mm-hmm. What I've heard is that, just like 10 or 15 years ago, everyone wanted this dual diagnosis kind of
Right.
stuff. Now the kind of hot thing is to be trauma informed.
Yeah.
So all these different treatment centers are looking to be trauma informed. And,
Mm-hmm.
so the question is, how much do they understand about complex trauma, which, as we know, is kind of a new developing field. Yeah. And then, so that's the first question. The second question is then what are the treatments that they're using for complex trauma? Because that's, another big piece of it that, we're waiting to kind of see how the research bears out. But some older models maybe don't work as well with complex trauma as they do with PTSD, with what we might refer to as shock trauma. So I think it's so new right now. That's why I wanted to kind of chat with you, because I know you've kind of been working on the ground with it.
Well, I think even to broaden it, I don't know that therapists understand what complex trauma is, because my students aren't getting it. Like I work both for Fordham University and Loyola University, which are pretty major universities. And I'm hearing from my students, like they don't know the difference between shock trauma and developmental trauma. And so we need to start there, in addition to like going into the treatment centers and making sure that people understand it.
Yeah. Yeah, well, that is one of the challenges we have in NARM, which is, is a model specifically designed for working with developmental trauma, that we are ahead of the diagnosis. We're ahead of the field. And in some ways, it's so super exciting for us, but it's also a little challenging because, like you said, people don't even have kind of a frame of reference for where the field's developing. And, for the last 35 years, more than 35 years now, 40 years, we've had this very strong frame of reference of looking through shock trauma and PTSD. And it's been incredibly helpful for us to move forward. But just like anything, things are evolving. And so we're now having much more nuance and understanding the overlap and the differences between event trauma and more kind of chronic relational trauma. So in terms of addiction, I mean, this is all just kind of what I've been putting together in my years of studying this, but it just seems like so much of what we're running from is really early trauma, early attachment, relational trauma that, we kind of embed into our systems, and then it shows up as symptoms. And then we do everything we can to kind of run away from the pain. And addictions, substances are a great way to run from pain.
Yeah. Well, I'm haven't completely crystallized this theory, but I feel like, and this is what really intersected with NARM, is that there are two types of people I see with addiction issues. And I have put it in a Buddhist framework just because that makes a lot of sense to me. And like, we are either avoiding pain or we're seeking pleasure. And so that's the two types of people that I see who end up in treatment centers. And the folks who are avoiding pain can usually point to their trauma. They really identify with having shame, and you know, they can tell you, yes, I started using because I wanted to numb the pain. And then there's this other group of folks who tend to present more on like the narcissistic side of the scale. And they always tell me my childhood was fine. I was just using for fun. And it's this pleasure seeking piece. And those clients, I find there's more denial, which I want to talk about denial from a NARM framework, because I think the way that NARM frames it is going to be different and more like client-centered. So there's more denial there and less of a recognition of the pain that may have happened, and maybe even like less opportunity to learn the resilience of dealing with pain. I've got a client right now who has come to this amazing spiritual awakening, and he's this type. He's totally this type. And he's told me I can share his story. And he, you know, only child, his parents were immigrants, very successful. He wanted for nothing, had a very easy life. And he'll say that too, that his life was super easy, and was just using for fun, ended up in treatment centers and all kinds of stuff. And now he just ended he ended an engagement and ended up having this spiritual awakening on the other side, and recognizing I've known him now for 6 years. And he said, I realize now after 6 years of this, I don't love myself. And it's taken that long for him to actually wake up to the fact that he's been doing all of these other things, because it started out with booze and then it became sex and workaholism and all of these things in order to cover this part of himself. But it took so long to open to it. And that's what's so exciting to me about NARM, is I feel like NARM can bypass that. Because that's what I've been looking for. I've been wanting to study denial and wanting to figure out, how do I get to that person earlier before they completely destroy their lives, you know?
Yeah. Well, and I mean, in some way, the way that you've described that client, it seems like the seeking pleasure was actually kind of a strategy for avoiding the really deep core pain that he experienced. Yeah.
Right.
Which really fits with our model of the identifications, the shame-based and the pride-based strategies.
Yeah. Exactly.
And so as he was able to kind of like, as you were able to help him kind of manage more of the pride-based strategies, he was able to really connect to the deep. I'm guessing there was a lot of grief and a lot of feelings there that hadn't been processed.
And we're just starting, because I think the grief and the anger, that's been so helpful for me to understand from that perspective, like giving those voice. And he's now at the space where he's ready to be angry at his parents for the first time in his life, because he had just been like, well, I have no right to be angry with them because they gave me everything I wanted.
Yeah, part of that denial.
Right. Yeah. Right. Yeah.
Wow. And do you see, as you're working kind of through these shame elements, the trauma elements, you see that his relationship to the addictive strategies are changing?
It is. He's put more boundaries around work. He's been sober for a while now, so that hasn't been an issue. But it's funny. As soon as he ended his engagement, he came in and he's like, so I bought a new car. I'm moving from my apartment and I have 3 dates this weekend. And then, you know, as I was like, okay, all right. So talk about strategies, right? And after a couple weeks of like really processing what had happened with this engagement that ended, he was able to recognize like, okay, that was a strategy. That was a reaction to the fact that I didn't want to feel. And the whole time we've been working together, every time he has negative feeling states, he's like, just fix it. Just take it away. Yeah. And I continue to tell him we need to be able to tolerate sitting in those feelings. And that kind of goes back to like that pleasure seeking person who just didn't form or didn't have the opportunity to develop ways of sitting with pain because there wasn't, you know, the pain wasn't obvious. Yeah. And so they just didn't get to practice.
Yeah. Well, that connects to a few things we've already talked about. I mean, one is just the diagnosis that's being developed around complex trauma. A main piece of it is what they refer to as affect regulation.
Right.
And how do we develop affect regulation, which is part of what you described before as resiliency, is through attachment, is through early childhood. And so when we have had disruptions in early childhood, then of course our affect regulation systems will be disrupted. And then that's going to lead to difficulty with resilience. And so this is kind of the whole stage being set for then when they turn into teens or young adults. Again, trying to manage life, whether it's, avoiding pain or even seeking pleasure. They're all different kind of strategies for that. So I wonder, just like, okay, so you've worked in treatment centers and you've had experience in consulting with them. Like, what do you feel from like this trauma-informed perspective would be most useful for them to know about?
That's a really good question. When we're in the treatment center, it moves really fast. So from a systems perspective, there are so many factors at play that are telling us how we need to work with people. So kind of, from the big in, I'll kind of talk about it. So, insurance companies are dictating how long people can be there. Money is dictating how long people can stay. Different states have different regulations about how you're supposed to do treatment, right? All these things are informing, and it feels like time goes really fast and you just don't have a lot of time to do anything. So truthfully, that's the first problem, is that the system is not set up to support the therapist to do the good work. Yeah. So that's the bigger picture. But within the treatment centers, I think if we can get people less interested in making sure that people stay sober, because that's the symptom, right? Is using the drugs, and sobriety would be a byproduct of really being able to support people in recognizing that their early lives shaped who they were. It will have to be a sea change, I think, because, and especially, paraprofessionals, God bless them and the work that they do, but them not having the education and the skills to really help somebody through this. If your treatment center is staffed with paraprofessionals and not licensed clinicians, that's also going to be a barrier. And I don't want to like say all paraprofessionals do this, but what I run into a lot is this, like, well, this is how I got sober. And so this is, my sponsor told me this. And so I'm going to do it this way too. We need people who are really equipped to take people on this road.
Yeah. And that doesn't lead to a very client-centered approach. If it's just like one way is the right way, you can lose a lot of people in the process. And I know I don't remember exact statistics, you probably would know better, but about how many times it takes people before they actually get sober after treatment. So, I think that, the bringing the humanity back into the treatment from the larger perspective, like you talked about, to like smaller perspective on just how we treat them. And I know that, part of, categorizing substance abuse as a disease was supposed to do that. It was supposed to kind of trying to bring humanity, but I think we're at another stage now with it.
I totally agree.
Yeah. So one of the things that, I was really intrigued by when we were first chatting about this is just kind of your perspective on 12-step, and 12-step such a big part, obviously, of so many treatment centers and treatment approaches. So now that you're, much more thoroughly immersed in the trauma world, what's your sense of what role 12 steps have? Do they fit? Do they work trauma informed? Do they need to be adapted or evolved? Like, what's your take on it?
So I want to give the caveat that, so I'm an Al-Anon, and I tell people that I'm an Al-Anon, and I realize I'm breaking the 12th tradition of anonymity. But I do that mindfully. Have you ever seen Anonymous People? Do you know that movie?
No.
So it's a movie by a guy, I think he's in recovery, and he talks about anonymity needing to be there in the 30s when they developed the 12-step, and it really served a purpose to keep people safe at a time when the stigma of addiction was absolutely unbearable, and it would destroy people's lives if anyone knew that you were in recovery. And he's essentially saying that now it's almost serves the opposite purpose, that there's so much misunderstanding with 12-step that we need to be speaking out and saying, hey, this is what 12-step is and this is what it isn't. So just disclaimer there. I know my sponsor would be like, you're breaking 11th and 12th tradition, but so I have an affinity for 12-step, and I remember early in my career having a lot of the feelings that I hear my students having now, or other people having now, about like, oh, it's religious and you're supposed to submit to this higher power, and, it's shaming and all these things. And I think that the 12 steps were a divine download, because just the fact that it's lasted this long and it has helped so many people, there's something greater going on. And just like, religion, like, it's the actors who are kind of putting forth the 12 steps that can be faulty. So I think it really depends on the delivery. And again, I think that it's very regional, and we're so lucky in Chicago to have a really great community for all of the 12 step groups. And a lot of them are fairly healthy, and treatment and 12 step are pretty separate. In Chicago, I think Hazelden is probably the last treatment center that's really 12-step facilitated, and I know that they're really trying to work to shift that.
Why is that?
Why
are these treatment centers trying to separate from 12-step?
Because it's not treatment. It's mutual help group. It's a totally different thing. It's not. I mean, 12-step facilitation is a type of treatment, and that when the evidence-based treatment started becoming hip, of course they put like 12-step into that to make it effective. But like you said, things are shifting, and we've come a long way from that. And, working in treatment centers, we would always encourage people to go to 12-step, and it's part of it. And what I say to people now is, I don't really care what you do, but you need to be surrounded by people who are trying to be the best version of themselves. And again, we're lucky that we've got a pretty robust refuge recovery group here. We've got smart meetings too. So there's like a bunch of different options for people, but there is something special about it. It really is spiritual work if people are doing it the way that it was intended to be done. And I personally believe that all of us have a spiritual malady. It's not just people who suffer from substance use disorders. I think that some sort of spiritual recovery is part of becoming your fullest self.
Mm-hmm. So I have a kind of NARM specific question for people that are watching this that are familiar with NARM. This will make sense. If not, we'll try to do the best we can to kind of give a definition to agency. But a big part of NARM is this understanding of kind of reinforcing agency, that when we have childhood trauma, we lose our ability to feel like we can impact the world and even impact kind of our relationship to ourselves. So how do you see agency fitting in with 12?
Yeah, that's a great question, because this is one of the things that you and Larry were talking about that I was like, but no, that's actually what the 4th step does.
Okay.
Because he was talking about, I think, agency being taken away. And again, the actors in 12-step can sometimes do that. And I've heard very shaming sponsors who are just like, just get on your knees and pray. That's not going to cut it. Like, there's just so many nuances, and humans are terrible with nuances generally, right? But the action of recognizing that you don't have control of all of the little specific things that happen to you is actually empowering. And I think about it like, I have goals, I have dreams, I have desires, and I have agency to make it happen. But at the same time, I can't will something to happen. I can't force someone to love me, or, I can't force my staff to stay with me forever, right? These things that I may worry about. But this is the serenity prayer. God grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. It's this yes about the difference between due diligence and fix, manage, and control. And I think that's where agency comes in with the 12-step. If you're kind of holding all of the pieces at the same time rather than discounting one side or the other. Mm-hmm. But I know a lot of, and I think too, like the label of addict, for some people it's shaming, for some people it's freeing. I have so many clients that say, after years of recovery, they say, I am so glad that I'm an addict, because it gave me the opportunity. It stopped me in my tracks and gave me the opportunity to look at my life and recognize I wasn't who I wanted to be. I hear that all the time. And I mean, like, that's that's what we want for people in recovery.
Mm-hmm. Well, that's good. Yeah. I mean, I think I like the yes and. I mean, you're holding the larger piece of that. And I think you're right. I mean, it is so personal. People have different relationships to it. So some people would give them their agency over to whether it's 12-step or a religion or a spiritual perspective or a political group or whatever it is. And then some people would be connected to the religion or the spirituality or whatever, but also still have their relationship that's based on their own sense of self. So
my therapist and I talk about it as co-creating. You know, if I think about my higher power and what I want in my life, we're co-creating together rather than it being just God's will or just my will.
Yeah. Yeah. That not only do I like that, but it seems like it really fits with this understanding of models that come from understanding attachment and interpersonal neurobiology and all the stuff in psychotherapy now that's really changing the way that we understand how this work is done effectively.
And to go to attachment, if you think about the caregiver as the higher power can then be a replacement for the caregiver that wasn't consistent and unconditionally loving.
It's true. Yeah. So the last piece is just like a general question. It's like, how important, from your perspective, is it that people are working on their developmental trauma in recovery? And like how can people do treatment successfully without addressing their early trauma?
I think that's part of why we see people continuing to cycle in and out of treatment, is not getting to the root of it. And I don't like to use the word relapse. Bill Miller, who did motivational interviewing and all that, the term that he likes to use is recurrence of symptoms. So I like to use that too, even though people don't know what that means. That means relapse essentially, but I think relapse just kind of has a shaming connotation. So people who end up cycling through treatment and continue to have symptoms, you know, I always tell them it's either because we missed something, or you weren't willing to do the things that needed to be done. And it's usually because of the underlying developmental trauma. That's why I'm so excited. Like NARM it fit into all of these things that I had questions about that I didn't know how to get to with clients. Mm-hmm. So I'm so excited that now I have this framework, and hopefully in April we'll have more mastery of actually being able to do it with clients to really help them get to that space where they don't have to punish themselves anymore.
Yeah. That'd be nice. Well, thank you so much, Sarah. This is great. I mean, I know this is the first of many conversations for us to be exploring together, but this is just a good start, you know, because I think things are really changing, not just in the trauma field, but in the treatment field. And we are ahead of the curve, and, you know, there's no formula for how to make this successful. So I think these conversations are just kind of brainstorm sessions for okay, where are the pain points and where do we need to kind of figure out how to bring this work in a way that's going to be supportive of what's already working well. Because, you know, NARM is not a replacement for things that are already working well.
Right.
So we're trying to figure out how can NARM as a model for working with early trauma, how can that be supportive of things that are already working? So I think that's, you know, part of these exciting conversations we're having. So.
Yeah. I mean, again, it's a yes and. People are going to need CBT skills because they're going to need to be able to have tools that they can pull on, but doing the underlying work at the same time. Yeah.
Great. Well, thanks, Sarah. Look forward to our next conversation.
Yay.
Okay. Bye.
Bye.